What we did is we compared patient characteristics and outcome of elderly, intensively treated patients with acute myeloid leukemia who were included in the control arm of a randomized HOVON trial with elderly, intensively treated patients from the Harmony Alliance and from the Dutch National Cancer Registry. We investigated to what extent these data could compare to the control arm of this HOVON trial. We looked at patient characteristics at baseline, so diagnosis, but we also matched these patients from the Harmony and Cancer Registry to the HOVON control patients using a one-on-one nearest neighbor propensity score method. And we included age, European Leukemia Net Risk Classification, and leukocyte count diagnosis, and also for Harmony patients, the WHO performance score. There were 278 control patients in the HOVON control arm. So we matched 278 patients from the Harmony Alliance to the HOVON controls and 278 patients from the Cancer Registry to the HOVON control patients. And what we found was that the baseline diagnostic patient characteristics, so age, sex, WHO performance score, and ELN risk classification, and leukocyte count were largely comparable. But the primary endpoint, 2-year overall survival after diagnosis, was not. Harmony patients reported to the Harmony Alliance had a 2-year overall survival that was comparable to the HOVON controls, 40% at 2 years for the HOVON control patients and 35% for the patients from the Harmony Alliance. But the patients from the Cancer Registry had worse overall survival, only 30%. We think that this might be explained or be attributed to the fact that there was a large population of trial patients included in the Harmony cohort who adhere to strict inclusion and exclusion criteria and have fewer comorbidities, which is not the case in the Cancer Registry population. And together, these results suggest that matched data from the Harmony Alliance might be used as external control data for prospective studies evaluating drugs in elderly, intensively treated patients with acute myeloid leukemia. This is a first example of testing the hypothesis, or one of the first examples that external control data, such as data from here, the Harmony Alliance or a National Cancer Registry, may supplement or replace the control arm of a prospective randomized clinical trial. And the problem with randomized control trials is that they are very robust design for efficacy, but they are limited by a long duration and a relatively high requirement of patient sample size. And this prevents the execution of sufficiently powered clinical trials in AML as more and more drugs are tailored towards specific patient subgroups. So I think that the impact of external cohorts might be that for newer and prospective clinical trials, fewer patients need to be allocated to the control arm, as these might be derived or can be derived from these external data sources. And hopefully this might accelerate trial recruitment.